So welcome to our very first pilot of Healthcare Research Bytes. So I'm very pleased to share this very first event with Hannah, a very dear friend. I'll just introduce myself very briefly. My name is Pinar Karaca-Mandic. I'm a health economist at the University of Minnesota, associate professor of finance, and also the academic director of the Medical Industry Leadership Institute. Sort of one of our goals with MILI is to enhance the university's research, capacity, infrastructure, and communications, really. And so we thought that one really cool way to do it is to do very quick, short, what we called research bites, where we can get to speak with one of the authors of a really cool paper that just got published, so we can share some new evidence, new information, and give you a chance to get to know some of the faculty. So with that in mind, for our February and inaugural Research Bytes, I reached out to Hannah, who's an assistant professor in the School of Public Health. And I reached out to her because I actually saw her paper through Twitter. Twitter is one of my sources to get new information on some of the new data, and people were discussing and tweeting, retweeting. So her paper called Physician Organization and the Role of Workforce Turnover was recently published in the Annals of Internal Medicine. Her co-authors are Mike Williams and Mike Chernow, both from Harvard. And so I wanted to tell a little bit about the topic, but I'll of course have Hannah do the insights, give the pure insights from the paper. But really what was kind of intriguing to me about the whole paper was they're looking at changes in physician organization, which has been on the radar screen for many of us as researchers, especially as we see physician practice groups consolidating and getting larger. So was some of the things, and there are very different explanations for it. But Hannah and co-authors are looking at it from a very unique angle. So I thought it would be great to meet Hannah and get her insight. So I'll defer to Hannah. I'll have Hannah introduce herself briefly. And
sure.
Maybe, yes.
Thank you, Pinar. It's wonderful to be the guinea pig of this new series. I'm so excited to be here and to talk about this paper. So my name is Hannah Neprash. Like Pinar said, I'm an assistant professor at the School of Public Health. I'm also a health economist by training, and most of my research focuses on the role of incentives in medicine and how those incentives shape the decisions that physicians make on behalf of their patients. So a lot of my work, I would say, including the paper that we're talking about today, looks at changes in this organizational landscape of medicine and what that means for healthcare financing and spending and prices and all those good things that economists like to think about.
Well, thank you. Yes, thank you so much for that introduction, Hannah. So I guess I'll just kind of we'll do it sort of like a fireside chat, although it's kind of an online virtual fireside, but so I guess I'll start with asking sort of what type of organizational changes in the structure of physician organizations, or what kind of trends did you guys notice and motivated you to even sort of think about and conceptualize this study?
Sure. So I would say we started from the point that you already mentioned, right, which is that the past decade or so, more than that at this point, has really seen a tremendous amount of consolidation of physicians into larger and larger groups. This is a big change. For a while, the way that medicine was practiced, it was usually physicians either in solo practice or one or two physician practices. And now we see the growth of these very large practices, 50 or more doctors, and they're increasingly affiliated in some way, whether that's ownership or contractual, with hospital systems. So this is a big shift. And a bunch of folks have been studying this for a little while now to understand the consequences for the healthcare system and for patients as well. And most of the research has focused on consolidation happening as a function of mergers and acquisitions in healthcare. But it occurred to us that that's not the only way that this that changes can happen in the organization of physician markets. There's always turnover happening. New physicians are finishing residency and entering independent practice. Older physicians are retiring or going into other fields. And so we really set out to understand whether this sort of natural turnover in the physician workforce was contributing to the trend of consolidation in physician markets.
Oh, that's very interesting. I mean, I find that angle very interesting, how it's very different incentives would apply to if you find that story versus it's a consolidation for a different reason, right?
Yeah.
Sorry. Next time in the webinar, I'll get water. So you ask a very specific research question. I don't know if it's because of the data you can get or because that was something that motivated you in a separate way. Could you tell us a little bit about the specific research question that you asked in this study?
Yeah, so we ask how practice characteristics, specifically practice size and ownership, whether a practice is owned by a hospital, how those characteristics vary among physicians who are just entering Medicare and physicians who are leaving Medicare. And I have to be very careful about my language because I think ideally we would have looked at new physicians and physicians who are retiring, and that is definitely, when you see physicians leaving Medicare, probably they are retiring. They do tend to be older, but as you know, that is one of the many limitations with research, right? Is that what you have.
Well, no, I mean, exactly, but I see exactly then, this is sort of like you have this ideal question in mind, but this is a good approximation to the question. So then that kind of leads me to what would have been sort of maybe the ideal data set for you to have to ask the ideal question, and then I will follow on and ask, what is the data set that you used?
So ideally, I think we would have been able to observe where physicians are in their career trajectory. So it would have been, it'd be great to be able to see, when does a physician finish residency and begin practicing independently, and when does a physician decide to retire and leave medicine entirely. The other thing that I think, in my ideal data set, we would observe how, exactly what the organization they worked in looked like. So how many peers did they have working with them? What was the structure of the practice? Was that practice owned, or did they collaborate with a hospital system? Kind of all of these intricate workings that vary tremendously, that are tough to find in actual data. What we did use, if I can share that.
Please.
We used a sample of Medicare claims. So we used 20% of Medicare claims, specifically claims submitted for services provided by physicians. And with those claims, we were able to do a couple of things that we had to do for the study. So our two outcomes really being practice size and practice ownership. So we basically used tax identification numbers as a marker of a physician's practice. So you can then count how many physicians are billing Medicare under that practice identifier. And then you can also observe whether practices and physicians are submitting claims in a way that suggests that they are owned by a hospital as opposed to being an independent office. Mm-hmm. I don't want to get too nerdy about this. Stop me if
I know. But it's like for the data nerds, those nuances are so important. I can give a little bit more insight as to like how can you identify in claims data, in such Medicare claims data or any sort of billing like data, what are some hints that you use to figure out who are the physicians practicing in hospital-owned settings versus not? Just a little hint, not getting into too much detail.
Sure. So to identify physicians that are practicing in a setting owned by a hospital, we took advantage of I want to call it a quirk of Medicare billing, which is that a physician in a hospital outpatient department can bill differently for the same service compared to if they were practicing in an office. And if their group practice is owned by a hospital, they can bill this extra amount. And we see that as kind of this powerful incentive to, to reveal your whether your practice is owned by a hospital or not, based on whether you get this extra payment from Medicare.
Yeah, nobody would deny the extra payment, so that's
exactly.
They have no reason not to.
Right.
So that lets you identify. Very cool.
Yeah.
What kind of physician characteristics can you identify, or did you use?
Yeah, so we brought in some data from a company called Doximity, which my understanding is they're essentially a social network of physicians. And from that, we could get information on age, which was really helpful because, like I mentioned, we want to be looking at new physicians versus retiring physicians. And what we can actually see is physicians who enter the Medicare claims for the first time, right, and physicians who, were billing Medicare and then they stop at some point. And so we were able to compare the average age among these two groups. Physicians who we see entering Medicare are much younger. On average, I want to say the average was about 34 years old, which is consistent with the age of someone who's finishing residency and going into practice by themselves. But for physicians where we saw them billing Medicare and then stopping and exiting Medicare, their average age was 65, which is also consistent with the idea that this group is mostly exiting Medicare because they are retiring.
Right. No, I think that's really clever. I use Doximity in my research too. I call it the Facebook of doctors.
There we go.
Right. So what kind of sample sizes are we talking about in this study?
Yeah, so we observed during the entire study period, so 2009 to 2016, we saw a little bit under 650,000 physicians, which is consistent with the, survey estimates of how many active doctors there are in the U.S. Mm-hmm. And within that group, there was quite a bit of turnover. So 19% of those doctors entered Medicare and started billing for the first time during our study mm-hmm. period, while about 12.5% exited Medicare. So turnover among physicians is it's pretty small per year, but it really adds up.
Mm-hmm. So going back to your research question and sort of coming to the results section of your paper, so what kind of big differences did you find between physicians entering Medicare versus physicians exiting Medicare, and did they make sense to you?
Yeah, so we found differences that I think they made sense, but they were even a little larger than I expected. So we found that physicians entering Medicare were much more likely to practice in the largest group settings. So that's practices that have 50 or more physicians. And they were much less likely, compared to physicians who were exiting Medicare, to join one or two physician practices. So clearly the practice setting of entering and exiting physicians is quite different. So to give some scale to that, we found that for every single doctor that was joining a small practice, 3 left during our study period. I see. And for every doctor that was leaving a large practice, 3 more entered that large practice on average. So there's really this kind of secular trend. The other thing I should say is that, right now we're talking about overall numbers, but when you drill down into specialties, there's a lot of variation. So these trends were especially pronounced among internal medicine specialists, mm-hmm. among ophthalmologists. I think neurology and dermatology were the other 2 specialties where there was a particularly large difference between the practice setting that entering physicians were going into and what physicians were leaving when they exited.
Yeah. I mean, I don't know the data or stats on it, but does it sort of roughly match to the consolidation trends that we also see in by specialty?
Yeah, yes, it does for sure. I think you see a lot of vertical integration. So the hospital ownership of physician practices has really taken off among internal medicine. So in that way, and also I think ophthalmology. So it's consistent in that way.
Was there anything sort of surprising to you guys? I mean, you said the effects were much larger than you thought.
Yeah. I mean, I don't want to get into implications too soon, but I think to me, I wish we'd written this paper 5 years ago, right? Because clearly turnover is something that's contributing in a meaningful sense to consolidation. And that even if we were to, even if like no more mergers or acquisitions happened in healthcare from today going forward.
This will happen, yeah.
This would still happen, yeah. And it's tough to say why exactly. I think there's a lot of speculation you can do, and there are some surveys of physicians finishing residency about what they want from their first job. And there's a preference for flexibility. People want more of a work-life balance.
Do we know any studies, or I mean, if not, then that's great, to look at sort of how graduating physicians or residents, how they perceive working in a large company versus a small company kind of questions?
Yeah, it's a good question that I don't know the answer to. I have come across, so there's not much in this research area, but there are a couple of surveys by medical staffing firms. And they show really a growing preference for practicing in a hospital employment situation. And that in the past 5 years or so has really, that used to be a minority of physicians, and it's much more common as the preferred setting now.
It's very interesting. Yeah. So you mentioned that you didn't want to get into implications. Well, you can get there.
Sure.
But so what, in the bigger picture, right, you identified this sort of turnover or demographics trend that also explains some of the trends that we see in the changes in the physician organization. And so what are some messages or takeaways for different types of stakeholders? Maybe I back one and say, who are the stakeholders for your study? And what are some of the messages and action items for them?
I think the stakeholders really range from, healthcare organizations that are trying to hire physicians and that are facing turnover in their own workforce, all the way up through policymakers who are thinking about antitrust and other options to encourage competition in healthcare markets. I think for the latter group, for policymakers and maybe antitrust enforcers, it does suggest that preventing mergers might not improve competition. That this kind of secular trend is happening and will probably continue to happen. And so my opinion is it kind of emphasizes the need to make independent practice more appealing, and to make it a little easier as a viable practice setting if we think that we want more competitive physician markets. It's important, I think, to put this research in the context of why do we care about competition in physician markets? Does it matter that there are fewer practices and they're increasingly very large? And I think for me, the answer is there's this growing body of evidence that shows that concentration or the lack of competition in physician markets is associated with higher prices, higher spending, and not necessarily an improvement in healthcare quality. That verdict is kind of out, but there's no good evidence that we're getting more bang for our buck in that way. So I think that that's an area where a lot more research is needed, and that's certainly an area where I've started to do some work as well, because I think it's an important one.
Will you give us a hint of your new work?
It's, you know, that work is still too early to even have results to share. I'm working on a paper right now, though, that's looking at the shift from fee-for-service to value-based medicine, and what that the relationship between that shift and physician turnover. So essentially, did ACOs lead to more turnover among physicians?
Right. No, that's very interesting. I mean, the one thing I would say, I would add on, you know, yes, the study implies definitely, you know, explaining mergers and acquisitions explain only part of the story.
Yeah.
But it is true that there's also this feedback mechanism, right?
Yeah.
To the extent that if there are more larger practices available for a new physician to enter,
Yep.
and I think another critical study to do would be to really look at the different types of incentives given to you know, for new hires.
Yeah.
From by the larger and the smaller organizations. I mean, sort of like, is it about the compensation packages? Is it about the work environment? Is it about learning opportunities, right? Is it about access to larger teams, access to larger enterprises and expertise? The other thing I wonder is, like, could it have something to do with liability risk? Like, does working in a larger organization for an entering physician, does it differ in terms of the liability risk they may be taking, right, compared to, you know, setting up and joining a small independent practice?
Right. I think that's a good, I don't know the answer to that question, but I think it's a good point that, you know, they're going into an independent practice, a small practice. I think it's a really risky decision, increasingly risky, given the administrative requirements and, you know, the ways that the medicine is changing right now. Yeah.
So no, I think we can talk with the Dean of Medical School and see if we can do a study on sort of figuring out incentives and what motivates graduating, you know, residents and physicians to what kind of positions and organizational forms.
I would love to do that with you, Pinar.
Thanks, Hannah. We have a few minutes if there are other questions to us, and we'll just give a pause. And Hannah, in the meanwhile, if you wanted to share other insights that I didn't ask you about, feel free to.
You asked great questions, I think. I liked your point that, you know, as these organizations get bigger, there are more opportunities to work for them, right? It's kind of it's tough to say if this is driven by changes in preferences among new physicians or by changes in opportunities to go work someplace, right?
Yeah, it's the denominator effect.
Exactly.
Right?
Exactly. Yeah. No, I totally.
Okay. Well, I didn't receive any questions, but I'll defer to Kim. Kim, if there is a way for you to solicit more questions, or.
If anybody has any questions, you're welcome to submit them. I know if you're on the phone, you know, you can certainly chime in as well. I know there's a way to raise your hand. So if there's anybody on the line, if you have any questions, just let us know.
And if they come up later, I'm happy to, please feel free to reach out by email.
Oh, thank you, Hannah.
Yeah, of course.
Well, thank you so much for your time. And, you know, we should do more of this. It's always better to be in person and, you know, have these conversations over coffee. But if we can do it virtually, we do it virtually. And that way we can disseminate the information to a larger group of people. And thank you for your insights. And, you know, I look forward to the new work that will follow this study.
Well, thank you for putting this together and for inviting me to participate. I loved it.
Thanks, Hannah.
All right.